They like to be able to offer this to their employees because it builds, it keeps the employees dependent on them or loyal to them, however you want to call it. But it's starting to get expensive. And this is happening at the same time that the focus, the kind of heart of the American economy, the American manufacturing, which is where health insurance benefits had really taken off, are now starting to face really stiff competition. Some of it from within the United States. You have a lot of these companies were unionized. Now for the first time they're really facing intense competition from the South, where companies are not unionized, they don't pay the same benefits. And more important, they're facing competition from abroad, from countries where labor costs are much lower. So the incentives suddenly turn around. And if you want to think of the sort of prototypical company of the 1950s, General Motors, and there was sort of a race to the top with health benefits. Everybody wanted to offer their employees better benefits. GM offered very rich benefits. Well, now, time goes by, the 70s and 80s, that process works in reverse. And you get to the point in the 1990s where the prototypical company is a company like Walmart. And now you have a race to the bottom of benefits. The game is how do you offer fewer people health benefits? How do you slim down? And you can do it lots of ways. You can pass more costs on to your employees, or you can do what that defense contractor in New York did, and you can start shifting over your workforce. Fewer full-time employees, more contractors, more part-time employees. And so this lovely graph that was going up turns around, and starting around 1970, it kind of levels off, and then it starts to decline. And keeps declining. And it gets to about where we are today, which is about 84% of the population, 83, 85, depending on how you want to count, has insurance. But that means 15, 16, 17% of the population does not have health insurance. And I can tell you that if nothing changes, as in if we don't have health care reform, that number will keep going down because the forces that are pushing it down are going to keep pushing it down. And this is not just a problem for people who don't have insurance. Lots of people have insurance, but they're underinsured. The insurance they have doesn't cover their medical needs. And meanwhile, we still have employers are struggling with the cost, and it's becoming a greater and greater burden on society. You hear about the deficit problem. People talk about we have an entitlements crisis in this country. We have a fiscal crisis in this country. Actually, we don't. We don't have an entitlements crisis in this country. We don't have a fiscal crisis in this country. We have a healthcare cost crisis in this country. If you don't worry about Social Security is fine. A little tweak in Social Security will be solvent forever. It's not discretionary spending. It's not even defense, although defense is, there's a pretty good case, I would argue, for spending less on defense, but that's not why. If you want to look at the federal budget, why we have this huge explosion, it's all in healthcare costs. It's all in Medicare and Medicaid. So we need to do something about it. Now, if I were king for a day, two things would be true. We'd get rid of the designated hitter rule in baseball, right? And that's how you do first. And then the second thing is we'd have a single-payer health insurance system. We would. I mean, I am a big proponent, big fan of single-payer health insurance. The system around the world that I, in some ways, admire most, the French healthcare system, works pretty much like a single-payer healthcare system. I think it's very instructive that Taiwan, which is a rapidly developing country that a few years ago had a chance to sort of go from scratch to creating any kind of healthcare system they wanted. They looked all around the world. They looked at every single model, and they thought, what is the best model? And they said, yes, a single-payer healthcare system. It works. If you want the question and answers, I can tell you why I think it works. I would have done that. Politically, it's a tough job to get that through the United States Congress. There is, however, a second way to do it, and this is sort of what I call the public utility model. This is a model that works very well in Switzerland and the Netherlands. And this model is basically the idea is that, all right, we're going to keep private insurance. We're going to have people get insurance through private insurers, but we're going to regulate the insurers almost like they're public utilities. And we're going to make them act like a government insurer. We're going to say you have to insure everybody. You can't exclude people for pre-existing conditions. You can't charge them more. You have to provide at least a common set of benefits. Now, to do that, the insurers are capable of doing that. And like I said, the system works real well in the Netherlands and Switzerland. But the insurers will then say, well, wait a minute. If you make us give insurance to everybody, we're going to get hit with that same adverse selection death spiral that happened to Blue Cross. Because you know what? People know they can get insurance when they get sick. They won't buy it when they're healthy. And you know what? They're right. It's true. So if you're going to do that, if you're going to make the insurers sell to everybody, you then have to turn around and you have to tell people, hey, guess what? You've got to participate in this system. Just like if we had Medicare, we're going to make you pay the taxes for Medicare. If you have single payer, we would make you pay the taxes for single payer. All right, well, if we're going to have this private insurance system, everybody has to participate. Now, of course, not everyone can afford to buy insurance. So then you have to say, all right, if we're going to make you get health insurance, we have to make sure you have the money to buy it. So we're going to subsidize it. We'll have a sliding income scale so that it's never unaffordable. At least this is the theory. And this is what they call the three-legged stool. Regulate the insurers, mandate participation in the system, subsidize people who need it. That's the system. It works great in the Netherlands, and it works great in Switzerland. And the Affordable Care Act was basically an effort to adapt that model to the United States, with some important differences. Number one being that because Americans don't like change, most Americans like the health insurance they have, we told people who have insurance through employers, we're just going to let you stay with that system. And in fact, we're going to assume that people with large employers will continue to get coverage from their employers. But for everybody else, we're going to say either if you're very poor, we'll just give you Medicaid, but if you're not below a certain poverty threshold, then we will create a system where you can buy insurance with these new insurance exchanges, these basically, which is like kind of a Expedia for health insurance. And we'll subsidize you, but we're going to make sure that you actually go and buy it. So that's the system, and it's not a perfect law. I'm the first to admit it. By the time this thing came through Congress, it didn't look a lot like I imagined it would look in my head when I sort of heard them talking about this. And you can see it in the numbers. It's a universal healthcare system that's not actually universal. It would basically mean the difference between 30 million people getting a health insurance, which means between 15 and 20 million people in this country would still not have health insurance according to the projections. A large chunk of them would be undocumented foreigners, but some of them would not be. So that's number one. Number two, a big part of this law is designed to control the cost of healthcare, because in the long run, that's what's driving this all. The fact it's not just that the insurance system is dysfunctional, it's that healthcare has gotten so expensive. And this is something that's built into the DNA of medical care, and I think you guys have talked about this a little bit. And it's not something you can solve with a silver bullet, but it is something you can start to address. And so this law basically takes a throw-at-the-wall strategy. Every cost containment strategy that any reasonable expert has thought of is in the Affordable Care Act as a pilot program. And the idea is you sort of throw it all at the wall and see what sticks. And whatever works, then double down on that. And on the one hand, is that guaranteeing that we're going to save a lot of money? No. But I will tell you two things. Number one, the law will pay for itself. And that part, that's not really controversial. I mean, there are people who say it won't. But if you look at the way the law is written, there are enough sort of guaranteed revenues in the law and guaranteed cuts to other programs that as long as no one changes those, there will be enough money to pay for the cost of expanding health insurance. So it's not really a question that this is going to make the deficit worse, if that's your worry. I mean, there's not really a question of whether this law should pay for itself. The question going forward is, will it actually make medical care less expensive? And that's harder to say. We can't be sure. But interestingly enough, in just the last year, we're starting to get evidence that the entire healthcare system is starting to turn around. Faster, I think, than a lot of us thought it would. You had your last lecture from someone talking about ACOs at hospitals, right? Stuff like that. I mean, I have been surprised, talking to leaders of the healthcare industry, the extent to which you are seeing changes from a number of large health systems turning around saying, you know what, we get it, this is going to be real, the incentives are changing, we need to be more efficient. And while I can't promise or guarantee this will make the cost of medical care lower, I do think we are seeing the early signs that the healthcare system is moving in that direction, which is about as much as I think you can hope for, because at this point, so much of what drives medical spending is so dispersed, and it has so much to do with the culture of medicine. It's not something you're going to be able to turn around on a dime. It's something you have to work on slowly. But that's okay, because when we think about it, look, we're never going to spend less money on healthcare than we do now. And we'll always, I think, we're going to keep spending more. The question is, can you lower that curve? Can you reduce the rate of increase to a point where it basically stays stable as a percentage of GDP? And at that point, even if we're spending 20% or 25% of our GDP on healthcare, which is a lot of money, and I hope we don't get to that point, at the very least, can we at least know that we're getting something for our money? Because that's the real shame of it. I mean, in theory, we spend 25% of GDP on healthcare. Is there something wrong with that? Is there a law of economics that says we can't do that? Well, no. We can spend 25% of GDP on whatever the heck we want. We can spend it on big TVs. We can spend it on bigger houses. So we spend on healthcare, as long as we're getting something for it. And that's the sort of shocking thing. When you look at statistics, people play with the numbers and they say, well, we're better at this and Europe's better at that. And, we can talk about that for a few minutes if you want. But the honest truth is, and I feel 100% confident, there is no way on God's earth you could argue that When we spend 16% of GDP on healthcare and the next closest country spends 12, and a bunch of them are at 11 and 10, we are not 4% of GDP better than them on results. At best, we're as good as the best of them overall. There's no way we're better. So clearly we're wasting a lot of money. And so that's the system we're going to get, I believe. The question is whether we get it. The election's coming up. I think we're going to rehash all the arguments we had in 2007, 2008, 2009. We'll start talking about death panels again, I'm sure. God, I should just I think I'm going to go back to all my old blog posts and just repost them, because I mean it's the same arguments over and over again. And then we have the Supreme Court. And you guys aren't a law school audience, which is good because I'm not a law professor. But I will just tell you very, very quickly, having tried to pretend to be a law professor, or at least a legal scholar on this, I am absolutely convinced that a faithful reading of the Constitution, in light of what we understand, have understood for 100 years to be the proper authority of Congress to regulate interstate commerce, and going back 200 years, the right of Congress to do whatever is necessary and proper to carry out its duties, I have no question at all that if you are true to those precedents, then the individual mandate is not even a close call. It is obviously constitutional. Now, the Supreme Court can say whatever it wants, and they may rule against it. It wouldn't shock me at this point. But if they do, I hope they have the honesty to admit that while the Constitution can say anything, it is a really vague document, they should admit that they are overturning those precedents, that they are turning the clock back 100 years and 200 years, which is kind of a shocking thing to do. And I hope people realize that. And I hope, honestly, for the moment, that the justices of the Supreme Court think about that. Do they really want to do that? Because in theory, even people who support judicial activism, even people who support decisions like Brown versus Board, Roe v. Wade, they believe that those rulings, when the court overrules democratically elected lawmakers, are special occasions for cases where of unambiguous violations of liberty, to be done with not 5-4 partisan votes. So we'll see. We'll see if they do that. We'll see if they pay attention to that. And hopefully, when I come back in a year or two or whenever, we'll be talking about how, in fact, it survived the court challenge, it survived the next election, and now the big question is, can they actually implement this law properly? So thank you. And I don't know, you have 10 minutes for questions, or? Yeah?
I have two questions. One is quick. Does that 85% estimate that you made?
Yep.
So you're saying 15% are uninsured. Are you including undocumented, residents or?
Yeah, that's the 16% uninsured you hear, the 15% for that includes all residents.
So it's
yeah.
a rough estimate of average.
But it's like every census, every study of this is a little different, and some of them count differently. So that's why I sort of try not to give an exact number for that. It's kind of a range.
And then my other question is, I think with sort of the political environment that we have, given the Citizens United ruling, there's a lot of individual people who I think are sort of funding a politician at this point. Do you think that that particular ruling has any influence in our healthcare going anywhere? Is it really what the people are wanting now, or do you feel like it's more an influence of people who are funding their politicians?